Hello, and welcome to another episode of Go Beyond A&P, where we explore the concepts that take anatomy and physiology beyond memorization and into understanding. So I want to begin today with two patients. Both walk into a clinic complaining of fatigue. Both get short of breath climbing a flight of stairs. Both have a hemoglobin of 8 grams per deciliter. So here's my question. Do they have the same problem? It would be tempting to say yes. After all, they both have anemia, and they even have the same hemoglobin concentration. But suppose the first patient has been slowly losing blood from a gastrointestinal tumor, and the second patient has chronic kidney disease and isn't producing enough erythropoietin. Same hemoglobin, same diagnosis of anemia, but from completely different physiological problems. And that's the central idea I want you to understand today. Anemia isn't really one disease. It's an outcome. Something has gone wrong somewhere in the system responsible for maintaining enough functional red blood cells and hemoglobin to support adequate oxygen delivery. Sometimes the bone marrow stops producing cells. Sometimes the kidney stops sending the appropriate signal. Sometimes the raw materials are missing. Sometimes the raw materials are present but can't be used properly. Sometimes the red blood cells are produced normally and then they're destroyed too quickly. And sometimes we're simply losing them faster than we can replace them. And if you watched the episode on types of hemoglobin, some of today's lecture will sound familiar. We've learned there that hemoglobin structure and synthesis matter enormously to red blood cell function. So today we're going to see what happens when hemoglobin production, or the red blood cells itself, goes wrong. And rather than memorizing a long list of anemia names, we're going to approach anemia the way I think it makes the most physiological sense. We're going to figure out where the system failed. And by the end, I want you to be able to look at terms like microcytic, macrocytic, hemolytic, or renal anemia, and not simply recognize the vocabulary. I want you to be able to explain why that anemia happened. Because once you understand the mechanism, the names become much easier to remember. But before we can understand how red blood cell production fails, we need to understand how it's supposed to work. Before we talk about anemia, let's build a healthy red blood cell. To do that, the body needs three things: a signal, a factory, and raw materials. So let's start with a signal. Your kidneys are constantly monitoring oxygen availability, and when oxygen delivery decreases, specialized cells in the kidney detect that change through an oxygen sensing pathway involving hypoxia-inducible factors, or HIFs. That ultimately increases production of a hormone that you've probably heard of before, erythropoietin, or EPO. EPO travels through the bloodstream to our second component, the factory, and that's the bone marrow. Within the bone marrow are hematopoietic stem and progenitor cells capable of eventually producing red blood cells. EPO doesn't magically create a mature erythrocyte. Instead, it promotes the survival, proliferation, and differentiation of erythroid progenitor cells as they progress towards becoming mature red blood cells. These developing cells pass through several stages and eventually become reticulocytes. Reticulocytes enter the bloodstream and finish maturing into erythrocytes. And that process is remarkably responsive. If tissue oxygenation falls, the kidneys increase EPO signaling, the marrow increases erythropoiesis, more reticulites enter circulation, and ultimately the oxygen carrying capacity of the blood can increase. But even with a perfectly functioning kidney and healthy bone marrow, there's still something else we need: raw materials. The marrow can't function and manufacture healthy red blood cells out of nothing. It needs iron to produce heme. It needs amino acids for globin synthesis. And it needs nutrients such as vitamin B12 and folate for normal DNA synthesis and cell division. So I want you to remember these three pieces: signal, factory, and raw materials, because almost immediately we're going to start breaking them. Chronic kidney disease, the signal fails. Aplastic anemia, the factory fails. Iron deficiency, we're missing a critical raw material. Vitamin B12, folate deficiency, the marrow has trouble completing DNA synthesis and normal cellular maturation. And later we'll encounter situations where all three are working, but mature red blood cells are being destroyed or lost. So instead of seeing anemia as dozens of unrelated diseases, we're going to start building a framework for understanding them. But when something does go wrong, one of our first clues may actually come from the red blood cells themselves, their size. So imagine I hand you 3 red blood cells. One is unusually small, one looks relatively normal, and one is unusually large. Without knowing anything else about the patient, those differences already give you information about where the physiology may have gone wrong. That's where MCV, or mean corpuscular volume, becomes useful. MCV tells us about the average volume, or essentially the average size, of a patient's red blood cells. Generally, an MCV below 800 femtoliters is considered microcytic. An MCV between 80 and 100 is normocytic, and an MCV above 100 is macrocytic. Those numbers are useful, but I don't want you to memorize them without understanding what they are telling you. So let's start with microcytic anemia. Why would a red blood cell end up too small? Often the problem involves hemoglobin synthesis. If an erythroblast can't produce enough hemoglobin, perhaps because iron is unavailable or globin synthesis is abnormal, the developing cell undergoes additional divisions before reaching an appropriate intracellular hemoglobin concentration. The result is a population of smaller cells. So when you see microcytosis, I want you to start thinking, what is wrong with the hemoglobin production? Now look at macrocytic anemia. Here the cells are unusually large. One important mechanism is impaired DNA synthesis, particularly with vitamin B12 or folate deficiency. The cell is trying to mature, but nuclear replication and cell division aren't proceeding normally. Cell division slows while cytoplasmic development continues. The result is an abnormally large cell, so macrocytosis should make you think about maturation and DNA synthesis, although not every macrocytic anemia is megaloblastic. And then we have normocytic anemia. This can be deceptive because the red blood cells may look perfectly normal in size. They're not just present in sufficient numbers. Maybe the kidney isn't producing enough erythropoietin. Maybe the bone marrow isn't producing enough cells. Maybe red blood cells are being destroyed. Or perhaps the patient has suddenly lost blood. So a normal MCV does not mean normal erythropoiesis. It simply means the average red blood cell that remains is approximately normal in size. And here's something important. MCV is a clue, not a diagnosis. A patient doesn't have microcytic anemia because microcytic anemia is the underlying disease. Microcytosis is a morphological pattern that tells us where to start looking. That's the distinction I want you to carry through the rest of this episode. But we're going to use 2 perspectives simultaneously. We'll ask, where do the red blood cells, or what do the red blood cells look like? But we'll also ask, What mechanisms produced that appearance? When we put morphology and physiology together, anemia becomes much easier to understand. So let's start breaking our normal erythropoietic system. What happens when the raw materials are available and the kidney is sending the signal, but the factory itself begins to shut down? Let's start with the factory. Imagine that the kidneys are functioning normally, erythropoietin is being produced, iron is available, vitamin B12 and folate are available. The body has everything it needs to make red blood cells, except for one major problem. The factory is shutting down. That's essentially what happens in aplastic anemia. Aplastic anemia is a bone marrow failure syndrome in which the hematopoietic stem cell population becomes severely depleted. And remember what hematopoietic stem cells produce, not just red blood cells. They also give rise to red blood cells, white blood cells, and platelets. Those are your formed elements. So aplastic anemia isn't simply just an anemia. Patients can develop pancytopenia, a reduction in all three major blood cell lines. That's why the bone marrow image on this slide looks so empty. Healthy bone marrow should contain a rich population of hematopoietic cells at various stages of development. In severe aplastic anemia, much of that hematopoietic tissue disappears and is replaced by fat. But why would the bone marrow suddenly stop producing blood cells? In many acquired cases, the problem appears to involve the patient's own immune system. Look at the right side of the slide. Activated cytotoxic T cells release inflammatory cytokines, including interferon gamma and tumor necrosis factor alpha. They can also activate death pathways involving the FAS and FAS ligand. The result is apoptosis of hematopoietic stem and progenitor cells. And if you watch the episode Antigen, How the Immune System Sees the World, there's an interesting connection here. In that episode, we talked about how T cells recognize molecular information and how extraordinarily powerful that recognition system can be. Here we see what can happen when an immune system response contributes to destruction of the body's own hematopoietic machinery. Now, look at the MCV on the slide. It's generally normocytic. And that makes sense. The primary problem isn't that the marrow can't make hemoglobin correctly. It's that the marrow can't make enough blood cells in the first place. So in our framework, the signal may be present, the raw materials may be present, but the factory has failed. And because that factory produces far more erythrocytes, the consequences extend well beyond anemia. So what happens, or what if the factory is perfectly capable of producing red blood cells, and that problem is that it never receives an adequate signal to increase production? That's our next failure point. So let's move away from the bone marrow and return to the kidney. Remember our normal system from slide 2. When oxygen delivery fails, the kidney senses that change and increases production of erythropoietin. EPO then travels to the bone marrow and essentially delivers the message, we need more red blood cells. But what happens when the kidney itself is failing? That brings us to renal anemia, particularly the anemia associated with chronic kidney disease. As chronic kidney disease progresses, the normal relationship between tissue oxygenation and erythropoietin production becomes disrupted. The body may be anemic. Tissues may need greater oxygen carrying capacity. The bone marrow may still contain erythroid progenitor cells capable of responding, but the kidney doesn't produce an appropriately increased amount of erythropoietin for the degree of anemia. I want to be careful with that wording. It isn't necessarily that absolutely no epigen is, or erythropoietin is being produced. The problem is that erythropoietin production is inadequate relative to the physiological need. And that distinction matters. Now, look at what happens downstream. EPO normally supports the survival and development of erythroid progenitors, including the VFU-E and CFU-E population shown earlier in our normal erythropoiesis pathway. But without adequate EPO signaling, those cells don't receive the survival and proliferative signals they need. Fewer cells successfully progress through erythropoiesis, fewer reticulocytes are released, and ultimately fewer mature erythrocytes enter circulation. Notice something else. The cells that are produced can still be approximately normal in size. That's why renal anemia is classically normocytic. The problem isn't primary cell construction, it's cell quantity. The factory can work, but it isn't receiving an adequate signal to increase production. So if aplastic anemia was factory failure, renal anemia is signal failure. Same eventual outcome, anemia, completely different mechanisms. And that's exactly why a hemoglobin value alone never tells us the entire story. So far, we've lost the factory. We've lost the signal. Now let's look at a very different problem. What happens when the raw material is actually present in the body, but the bone marrow can't get access to it? This is one of my favorite mechanisms in the entire presentation because at first it seems completely backwards. Imagine a patient with anemia. You might reasonably think maybe they're iron deficient, so you look at iron stores, and there's iron in the body. Sometimes there's plenty of it. Yet the bone marrow behaves as though iron isn't adequately available. How can you have iron and still develop anemia related to restricted iron availability? The answer involves a small peptide hormone produced primarily by the liver called hepcidin. And hepcidin is one of the most important regulators of iron metabolism. So let's follow the pathway shown on the slide. During chronic inflammation, immune cells release inflammatory cytokines. One particular important cytokine here is interleukin-6, or IL-6. IL-6 stimulates the liver to increase production of hepcidin, and hepcidin then interacts with a protein called ferroportin. Ferroportin is an iron export protein. So you can think of it as a doorway that allows iron to leave certain cells and enter the circulation. You'll find it on cells such as intestinal enterocytes, which absorb dietary iron, and macrophages, which recycle iron from old red blood cells. When hepcidin binds to ferroportin, ferroportin is internalized and degraded. In other words, the iron export door gets removed. Now, look at the consequences. Iron becomes trapped inside macrophages instead of being released back into circulation. And iron absorbed by intestinal cells has more difficulty reaching the bloodstream. The body's iron stores may therefore be adequate or even increased, while the amount of iron available for erythropoiesis decreases. This is sometimes described as functional iron deficiency. The iron exists, the marrow simply can't access enough of it. Why would the body do something that seems so counterproductive? There is actually an evolutionary logic to it. Many microorganisms and pathogens require iron to reproduce. During infection and inflammation, reducing circulating iron can help deprive pathogens of a resource that they need. In the short term, that's potentially productive. But when inflammation becomes chronic, that same defense mechanism can interfere with erythropoiesis. The result is anemia of inflammation and sometimes called anemia of chronic disease. And notice that this is often normocytic, especially early on, although it can become microcytic in some patients. So now we have our third failure. Aplastic anemia is the factory. Renal anemia, it's the signal. Anemia of inflammation, it's a failure of raw materials. But access to it is restricted. 3 patients can all have low hemoglobin, but physiologically they're experiencing 3 completely different problems. And that brings us to an important distinction. There's a big difference between having iron that you can't access and simply not having enough iron at all. And that's where iron deficiency anemia comes in. So on the last slide, we had iron in the body. We just couldn't get enough of it to the bone marrow. Now we're going to change the problem. This time we're actually running out of iron. And to understand why that matters, we need to remember something about the episode on types of hemoglobin. At the center of every heme molecule is an iron atom. That iron is what allows hemoglobin to reversibly bind oxygen. So if the body doesn't have enough iron, it simply doesn't have a nutritional problem. It has a hemoglobin production problem. So let's follow the progression on this slide. Iron deficiency usually doesn't begin with anemia, and that's a very important point. The body has iron reserves, much of which are stored in association with ferritin. So early in iron deficiency, the body begins drawing down those stores. At this stage, hemoglobin may still be relatively normal, but as those stores or those reserves become depleted, there eventually isn't enough iron available to support normal heme synthesis. Now, hemoglobin production begins to fall, and that's when the red blood cells themselves begin to change. Remember what we said earlier about microcytic anemia? When developing erythrocytes can't accumulate enough hemoglobin, they tend to undergo additional divisions before maturation. And the result is a population of cells that are smaller than normal, and that's called microcytosis. They're often paler than normal because they contain less hemoglobin. That's called hypochromia. So when you hear the classic description of iron deficiency anemia as microcytic hypochromic anemia, don't memorize those words as random characteristics. They're telling you exactly what went wrong. Not enough iron means not enough heme. Not enough heme means not enough hemoglobin. And inadequate hemoglobin synthesis changes the size and appearance of the developing red blood cell. Now, why might someone become iron deficient? One possibility is simply inadequate intake. Although in many adults, we also have to think about chronic blood loss. That might be obvious, such as heavy menstrual bleeding, or it might be hidden, such as a slow gastrointestinal blood loss occurring over months or even years. So iron deficiency anemia can sometimes be more than a diagnosis. It can be a clue. The anemia may be telling us that there is something else happening somewhere in the body. In our framework, though, the fundamental failure is straightforward. The signal can work, the factory can work, but we're running out of essential raw materials. But here's where iron metabolism gets even more interesting. What if the body has iron? The iron reaches the developing red blood cell, and the cell still can't build heme correctly. That's a very different problem. So now we've looked at iron deficiency anemia and the anemia of inflammation separately. So let's put them side by side. But here's the problem. If I tell you that a patient has anemia and a low serum iron, you immediately think iron deficiency anemia, but not necessarily. Both iron deficiency anemia and anemia of inflammation can produce a low serum iron. The difference is why the iron is low. Think about two patients who walk into the grocery store looking for food. The first patient walks into the store where the shelves are empty. There simply isn't any food available. That's absolute iron deficiency. The second patient walks into a store with a warehouse full of food, but the warehouse is locked. The food exists. That patient just can't get to it. That's closer to the functional iron restriction we see with anemia of inflammation. And the laboratory values on the slide help us distinguish between those two situations. Let's start with ferritin. Ferritin reflects stored iron. In true iron deficiency, we're actually depleting the body's iron reserves, so ferritin becomes low. But remember our patient with inflammation. That patient may have iron sitting inside macrophages, trapped there because the hepcidin ferroportin pathway we discussed earlier. So ferritin may be normal or elevated. And there's another reason ferritin can rise. Ferritin is an acute phase reactant. So inflammation itself can cause it to increase. Now look at TIBC, or total iron binding capacity. TIBC largely reflects the amount of transferrin available to bind iron. In iron deficiency, the body essentially recognizes that iron is scarce and increases its capacity to transport it. So TIBC tends to go up. In anemia of inflammation, TIBC tends to go down. And now look at serum iron. It's low in both. That's exactly why serum iron by itself doesn't solve the problem. And finally, we have TSAT, or transferrin saturation. The percentage of available transferrin binding sites actually occupied by iron. And again, that's low in both conditions. So I don't want you to look at any one laboratory value in isolation. I want you to recognize the pattern. Low ferritin, high TIBC, low serum iron, think absolute iron deficiency. Normal or high ferritin, low TIBC, low serum iron, think anemia of inflammation and iron sequestration. Same low serum iron, completely different pathology. And that's really the message of this slide. One patient has empty iron stores. The other has iron that's effectively locked away. But there's actually a third possibility. What if iron isn't absent and it isn't locked away? What if the iron reaches the developing red blood cell, but something goes wrong when the cell tries to use it to build hemoglobin? This slide gives us two very different disorders, but they both have something important in common. In both cases, the problem isn't simply getting iron to the bone marrow. The problem is making normal hemoglobin once we're there. Let's start on the left side with sideroblastic anemia. Remember that hemoglobin has two major components, heme and globin. And iron has to be incorporated into the porphyrin ring to produce heme. Several steps involved in the heme synthesis occur in the mitochondria of developing erythroid cells. In sideroblastic anemia, that pathway is disrupted. Your slide gives ALAS2 mutations as one example of how this can happen. The important point is that iron enters a cell, but it can't be incorporated normally into protoporphyrin to make heme. So now we have iron with nowhere useful to go. It begins accumulating within mitochondria, and because those iron-loaded mitochondria surround the nucleus of the developing erythroblast, iron staining procedure produces that distinctive ring. That's the ring sideroblast shown in the middle of the slide. So when you hear ring sideroblast, don't just memorize the appearance. Ask, why is the iron sitting there? Because it arrived at the factory, but the heme production memory couldn't use it correctly. Now move to the other side of the slide. Here's where we encounter thalassemia. And this time, heme isn't necessarily our fundamental problem. The other problem is the half of the hemoglobin, globin. If you watched the episode on hemoglobin, you'll remember that the normal adult hemoglobin requires globin chains produced in the correct proportions. In thalassemia, there's a genetic quantitative defect in the production of either alpha or beta globin chains. And that word quantitative is important. We're not talking primarily about making a structural abnormal globin chain. We're talking about making too little of a particular globin chain. That creates an imbalance. For example, if beta globin production fails, alpha chains can be left without enough beta chains to pair with. Those unmatched chains can precipitate and damage developing erythroid cells. The result can include ineffective erythropoiesis and premature red cell death. So look at the contrast on this slide. In sideroblastic anemia, we have a problem with heme synthesis. In thalassemia, we have a problem with globin chain synthesis. Different defect. Both interfere with our ability to manufacture normal hemoglobin, and both can produce microcytic anemia. That's why I keep coming back to the idea. MCV gives you a clue. It does not give you a diagnosis. A small red blood cell doesn't automatically mean iron deficiency anemia. You still have to ask, why is that cell small? So far, most of our microcytic anemias have brought us back to one central problem: hemoglobin synthesis. Now, we're going to leave the hemoglobin synthesis behind and ask a completely different question. What happens when a developing cell can't copy its DNA? So think about what has to happen every time an erythroid precursor divides. Before one cell can become two, it has to copy its DNA, and then those daughter cells have to do it again and again and again. That's happening constantly in the bone marrow. So what would happen if we interfered with DNA synthesis? That's the central problem in megaloblastic anemia. Your slide focuses on two nutrients that are critical to this process: vitamin B12 and folate. Both are involved in pathways necessary for normal nucleotide metabolism and DNA synthesis. And the slide specifically points us towards thymidine synthesis. If B12 or folate becomes deficient, normal DNA synthesis becomes impaired. Now, here's where things get interesting. The entire cell doesn't simply stop functioning. The problem disproportionately affects the cell's ability to replicate its DNA and complete normal cell division. As your slide describes it, the cell essentially becomes arrested while other cellular processes continue. RNA synthesis can continue. Protein synthesis can continue. Hemoglobin production can continue. The cytoplasm continues to mature, but the nucleus can't keep pace with because DNA synthesis and cell division are impaired. So the cells get bigger without dividing normally. And that's how we move from the microcytic disorders we've been discussing to a macrocytic anemia with an MHC greater than 100. Now, B12 and folate deficiency can produce very similar looking abnormalities, but they aren't necessarily caused by the same underlying problem. Your slide specifically mentions pernicious anemia as an important cause of vitamin B12 deficiency. In that situation, autoimmune atrophic gastritis interferes with the normal process needed for B12 absorption. Folate deficiency, on the other hand, disrupts the same broad DNA synthesis process through a different nutritional pathway. And this is where laboratory testing can help us distinguish them. The slide shows homocysteine as elevated in both deficiencies, but holotranscobalamin is identified here as a specific marker for B12 status. So once again, the laboratory findings aren't random facts. They're biochemical clues pointing us back toward the pathway that failed. But I want to stop here before we talk too much about what gives these cells, or before what these cells actually look like. Because this slide gives us the biochemical mechanism. This next slide gives us something even better. It shows us the morphologic evidence of that mechanism. If DNA synthesis is falling behind while the rest of the cell continues to mature, we should actually be able to see evidence of that mismatch under the microscope. And we can. And that leads us perfectly into the next slide. So on the last slide, we talked about the biochemical problem in megaloblastic anemia. DNA synthesis is impaired, cell division slows, but other parts of cellular development continues. Now, I want to show you what the actuality looks like. Because the microscope gives us a remarkable window into what's happening inside the cell. The key concept of this slide is something called nuclear cytoplasmic asynchrony. This sounds complicated, but the idea is actually pretty simple. The nucleus and cytoplasm are maturing at different rates. Remember, DNA synthesis is essential for normal nuclear development and cell division. When vitamin B12 or folate deficiency interferes with DNA synthesis, nuclear maturation is delayed. But RNA and protein synthesis can continue. So cytoplasmic development keeps moving forward. In other words, the cytoplasm is ready before the nucleus is, and they are out of sync. That's nuclear cytoplasmic asynchrony. And you can actually see evidence of that mismatch in the developing erythroid cells shown on this slide. The nucleus looks immature relative to the more developed cytoplasm. This isn't just an interesting microscopic finding. It's the physical evidence of the biochemical process we discussed on the previous slide. Now look at the neutrophil. Normally, a mature neutrophil has a segmented nucleus, but in megaloblastic anemia, we can see the hypersegmented neutrophils. Your slide defines this as a neutrophil with more than 5 nuclear lobes. Again, don't memorize that as some random association. B12 deficiency equals hypersegmented neutrophils. But ask why. The neutrophil is another rapidly produced bone marrow cell affected by abnormal DNA synthesis and nuclear maturation. So the abnormality isn't limited to red blood cells. We're seeing evidence of a broader problem with rapidly dividing hematopoietic cells. And I think this is a great example of something we're seeing repeatedly throughout this episode. Morphology tells us a story. A microcytic cell tells us where to investigate hemoglobin synthesis. A ring sideroblast tells us iron has accumulated where it shouldn't. And a hypersegmented neutrophil tells us something is wrong with normal nuclear maturation. The microscope isn't simply showing us what the disease looks like, it's giving us clues about why the disease happens. So up until this point, most of our anemias have involved some problem with producing or maturing red blood cells. But now we're going to change the question completely. What if the bone marrow successfully makes a red blood cell and something destroys it after circulation? Now we enter the world of hemolytic anemia. And the basic concept is straightforward. A normal red blood cell should survive in circulation for around 120 days. If those red blood cells are destroyed prematurely and the bone marrow can't replace them quickly enough, the patient becomes anemic. But on this slide, we're looking at a very specific reason for that destruction. The immune system is attacking the red blood cells. This is called autoimmune hemolytic anemia, or AIHA. And if you watch the episode Antigen, How the Immune System Sees the World, this is a nice clinical connection to something we discussed there. Antibodies recognize specific molecular targets. In autoimmune hemolytic anemia, that recognition is directed against antibody or antigens associated with a patient's own red blood cells. Essentially, the immune system has mislabeled itself as a target. Your slide separates autoimmune hemolytic anemia into two major forms: warm AIHA and cold AIHA. So let's start with warm autoimmune hemolytic anemia. Here, the slide identifies IgG antibodies as the major players. These antibodies coat the red blood cells. As that antibody-coated erythrocyte travels through the spleen, splenic macrophages recognize it, and something sometimes interesting happens. Rather than immediately consuming the entire red blood cell, the macrophage removes a portion of its cell membrane. The cell loses membrane surface area, but retains much of its internal volume. So instead of maintaining its normal biconcave shape, it becomes more spherical. And that's how we get the spherocytes shown on the slide. And those spherocytes are less deformable, making them particularly vulnerable to being trapped and destroyed in the spleen. Now, compare that with cold autoimmune hemolytic anemia. Here, your slide identifies IgM antibodies. IgM can activate the complement system, and that complement activation contributes to red cell destruction. So both disorders involve an immune attack against erythrocytes, but they're not identical. Warm AIHA is associated with IgG, splenic macrophages, and spherocyte formation. Cold AIHA is associated with IgM and complement activation. And your slide gives us one more important diagnostic clue, the direct antiglobulin test, or DA test, which is positive. You may also hear this called the direct Coombs test. Conceptually, we're asking whether antibodies or complement are attached to the patient's red blood cells. So once again, the test makes much more sense when we understand the mechanism. We're not just ordering a test for hemolytic anemia, we're looking for evidence that the immune system has physically marked the red blood cell. But antibodies aren't the only reason red blood cells can be destroyed prematurely. Sometimes the problem isn't coming from outside the red blood cells. Sometimes the defect is built into the cell itself. This slide gives us two examples of intrinsic red blood cell defects. And I really like putting these two disorders together because they show us that intrinsic hemolysis can arise from completely different problems. On one slide, we have a problem with protecting hemoglobin from oxidative damage. On the other, we have a problem with hemoglobin structure itself. So let's start with G6PD deficiency. Red blood cells are constantly exposed to oxidative stress. To protect themselves, they rely on an antioxidant system involving glutathione. But maintaining glutathione in its protective reduced state requires NADPH. And as your slide shows, the enzyme glucose-6-phosphate dehydrogenase, or G6PD, plays a critical role in generating that NADPH. If G6PD activity is deficient, the red blood cells become much more vulnerable to oxidative injury. The patient may be fine under ordinary circumstances, but then oxidative stress occurs. Your slide gives examples as infection, fava beans, and sulfa drugs. Now, the red blood cell can't adequately defend itself. Hemoglobin becomes oxidized and denatured. Those damaged hemoglobin molecules aggregate into structures called Heinz bodies. As the affected red blood cell passes through the spleen, macrophages remove the damaged portions of the cell, and that produces one of my favorite morphological clues, bite cells. They look as though someone literally took a bite out of an erythrocyte, and in a way that's essentially what happened. Now, let's move to the other side of the slide, sickle cell disease. Here, the problem isn't an antioxidant protection, it's the hemoglobin molecule itself. The slide identifies the mutation as a beta globin substitution of valine for glutamic acid, producing hemoglobin S, or HbS. And if you watch the episode on types of hemoglobin, this is where that earlier discussion becomes clinically important. A seemingly small change in the amino acid sequence can dramatically change the behavior of an entire hemoglobin molecule. When hemoglobin S becomes deoxygenated, the molecules can stick together and form long polymers. Those polymers distort the red blood cell. Instead of remaining a flexible biconcave shape, the cell can develop the characteristic sickle shape. And that creates two major problems. First, these abnormal cells are fragile and can be destroyed prematurely. That's the hemolytic anemia component. But second, sickled cells can obstruct small blood vessels. That's vaso-occlusion. So sickle cell disease isn't simply an anemia. It can also become a disease of impaired blood flow and tissue ischemia. Now, compare the two disorders. In G6PD deficiency, oxidative stress damages hemoglobin because the cells can't adequately protect itself. In sickle cell disease, an inherited alteration in beta globin changes the physical behavior of hemoglobin itself. One produces Heinz bodies and bite cells. The other produces HbS polymerization and sickling. Different intrinsic effects, same broad consequence. The red blood cell doesn't survive as long as it should. And that's the defining idea behind hemolytic anemia. So far, we've seen almost every imaginable way to become anemic. We can fail to produce red blood cells, build them incorrectly, mature them abnormally, and destroy them too soon. But there's one final possibility. What if the red blood cells are completely normal and we just simply lose them? So we've now seen what happens when red blood cells aren't produced correctly, when they don't mature correctly, and when they're destroyed too quickly. But there's one more way to become anemic. You can simply lose them. And that's what's interesting about blood loss, is that anemia can look very different depending on when we examine the patient. Your slide shows this as a timeline, beginning with acute blood loss and progressing towards chronic blood loss and iron depletion. So let's imagine a patient who loses a significant amount of blood. Maybe it's trauma, maybe it's surgery, maybe it's an acute gastrointestinal hemorrhage. At the moment that bleeding occurs, the patient isn't selectively losing red blood cells, they're losing whole blood. Plasma and red blood cells are leaving the circulation together. That's why the hemoglobin concentration immediately after a major hemorrhage may not initially reflect the full severity of the blood loss. The patient may have lost a tremendous amount of red blood cells, but they've also lost plasma. As fluids begin shifting from the interstitial space into the circulation, or as we give the patient intravenous fluids, the blood becomes diluted. Now, the decrease in hemoglobin becomes much more apparent. Meanwhile, the body recognizes that oxygen carrying capacity has fallen. The kidneys increase erythropoietin production. The bone marrow responds by increasing erythropoiesis, but that response isn't instantaneous. It takes time to manufacture new cells. After several days, we begin seeing an increase in reticulocytes entering the circulation. And that's important because it tells us something we've talked about throughout this episode. The marrow is responding appropriately. The factory works. It's trying to replace what is lost. Now, let's change the story. Instead of losing a large amount of blood at once, imagine losing a very small amount every day. Maybe the patient has heavy menstrual bleeding. Maybe there's a slow bleed, a gastrointestinal lesion. The individual losses may not seem dramatic, but remember what's inside every red blood cell: iron. Every time we lose blood, we lose iron with it. Eventually, the body's iron stores begin to fall. Ferritin decreases. Hemoglobin synthesis becomes impaired. And now the red blood cell begins becoming microcytic. So blood loss can actually change its appearance over time. Acute blood loss is generally normocytic, but chronic blood loss can eventually produce iron deficiency anemia and microcytosis. That's why I like the title of this slide so much: the time to depletion. The mechanism hasn't necessarily changed. The patient is still losing blood, but as time passes, the physiological consequences evolve. We've now seen nearly every major way red blood cells and that system can fail. So if a patient walks into your clinic with anemia, how do you organize all of this without memorizing a giant list? You can use physiology. This is the slide where everything we've discussed comes together. And if you remember only one framework from this episode, I would make it this one. When you discover that a patient is anemic, there are two major questions that can immediately help organize your thinking. The first is, what do the red blood cells look like? That's the morphologic question. And MCV helps us answer it. Are they microcytic? Are they normocytic? Or are they macrocytic? But morphology alone isn't enough. So we ask a second question. What is the bone marrow doing about the anemia? That's the kinetic question. And one of our best clues is the reticulocyte response. Think about normal erythropoiesis. If red blood cells suddenly disappear from circulation, a healthy kidney and healthy bone marrow should respond. Erythropoietin increases, erythropoiesis accelerates, reticulocytes increase. So if a patient is anemic and the reticulocyte response is appropriately elevated, that tells us the bone marrow is trying to compensate. Now we start thinking about red blood cells that are leaving the circulation after they've been produced. Maybe they're being destroyed as in hemolysis, or maybe they're being lost as in hemorrhage. But what if the patient is anemic and the reticulocyte response is inappropriately low? Now we have a different problem. The marrow isn't adequately replacing the red blood cells. So we start looking upstream. Is the kidney failing to produce an adequate erythropoietin response? Is the bone marrow itself failing? Are essential nutrients missing? Is inflammation interfering with erythropoiesis? Is DNA synthesis abnormal? Now, combine that with kinetic information with the MCV. If the cells are microcytic, think about hemoglobin production, iron deficiency, thalassemia, sideroblastic anemia. And sometimes anemia of inflammation if the cells are macrocytic, think about abnormal maturation. And in the context of this presentation, particularly the megaloblastic processes involving B12 or folate. And if the cells are normocytic, the reticulocyte response becomes especially helpful in separating inadequate production from increased loss or destruction. Your slide also brings in several of the laboratory clues we've encountered throughout this episode. Iron studies, markers of hemolysis, and the direct anti-globulin test. But I don't want you to see those as disconnected laboratory values. They're pieces of a physiological story. Ferritin and TIBC help us understand iron availability. The reticulocyte response tells us whether the marrow is responding. Bilirubin, LDH, and haptoglobin can provide evidence of red blood cell destruction. And the direct anti-globulin test can help determine whether that destruction has an immune mechanism. So instead of asking which list of anemia symptoms and laboratory values did I memorize, ask what do the cells look like? Is the marrow responding? And then where did the system fail? And if you can answer those three questions, you've moved beyond memorizing anemia classifications. You've reasoned through the physiology. So at the beginning of the episode, I introduced you to two patients. Both were tired, both became short of breath after climbing a flight of stairs, and both had a hemoglobin of 8 grams per deciliter. Then I asked you, do they have the same problem? Now we know the answer is not necessarily. One patient could have iron deficiency anemia because chronic blood loss has gradually depleted the body's iron stores. Another could have chronic kidney disease and an inadequate erythropoietin response. Another could have perfectly adequate iron stores, but inflammation has made that iron less available for erythropoiesis. Another could have impaired DNA synthesis because vitamin B12 or folate deficiency. Another could have intrinsic red blood cell defect that causes those cells to be destroyed prematurely. Another could have bone marrow failure, same outcome, anemia, completely different physiology. And that's a central idea I hope you take away from this episode. Anemia is not just one disease. It's a sign that something has gone wrong somewhere in the system responsible for maintaining adequate red blood cells and hemoglobin. So when you encounter anemia, don't immediately reach for a memorized list of diagnoses. Start with the physiology. Ask, what do the cells look like? Is the bone marrow responding appropriately? And most importantly, where did the system fail? Was there a problem with the signal, the factory, the raw materials? Was the hemoglobin assembled incorrectly? Was DNA synthesis impaired? Were otherwise functional red blood cells completely destroyed prematurely? Or were they simply lost? Once you begin thinking about anemia this way, all of those different names become much easier to organize because you're no longer memorizing a list. You're following the red blood cell throughout its life and figuring out where the story went wrong. So, thank you for joining me for this episode of Go Beyond A&P. Learn it for the exam, understand it for life, and until next time, stay curious and keep learning.